Carotid stenosis is the leading cause of stroke, yet the symptoms can be subtle. On this edition of Being Well, interventional cardiologist Dr. Al-Dadah will be here to explain this disease. Risk factors such as age, high blood pressure, smoking, and high cholesterol can lead to carotid stenosis. Dr. Al-Dadah will talk to us about how it's diagnosed and the treatment options available. Finally, we'll get some heart health advice we can all follow right now. Don't go away. Being Well starts now. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first. Welcome back to this edition of Being Well. I'm Lori Banks, and today we have an interventional cardiologist with us from Prairie Heart Institute. Dr. Al-Dadah joins us. Thanks for coming over.
Thank you for having me.
So tell us a little bit about your practice and the kinds of cases that you see.
Well, I'm an interventional cardiovascular specialist.
Okay.
So my specialty involves the heart as well as the vascular beds of the body.
Okay.
And I treat narrowing of the blood vessels in the body.
Okay.
Whether it's within the heart muscle itself or outside the heart muscle. That includes the carotids as well as the leg arteries.
Okay.
And essentially, we utilize modern technology, modern information to help the sequela of these diseases. Not so much as just because we saw the disease, we want to go ahead and treat it. No, if it's causing problems, if it's causing symptoms for the patient, we will go ahead and treat. And we have numerous types of technologies that we can utilize to treat these patients.
So are you seeing, as you've been in this field, are you seeing more and more patients come in with issues, heart issues, carotid stenosis, which we're going to be talking about in just a little bit?
We do see an increase of coronary artery disease as well as peripheral vascular disease and carotid stenosis, to be specific. And I think a lot of this, why we're seeing more and more of these patients, is because we are seeing more and more Asian Americans. And that's why we're picking up a lot more signal, so to speak, of these patients.
Okay. Well, when we talked to you about what topics you wanted to cover, you said, I'd like to talk about carotid stenosis. And when I heard the word stenosis, think of spinal stenosis, which is a back issue. So what's carotid stenosis?
Stenosis is basically a narrowing of a lumen. So when you hear it within the spinal realm, it's the spinal canal where the spinal cord runs through. And it has neurological sequela, different than the neurological sequela that we see with carotid artery stenosis. Carotid artery stenosis is the narrowing of the blood vessels that give nourishment and blood supply to the brain.
Okay.
Disruption of the flow results in strokes and neurological deficit. And how does it come about? It's plaque buildup.
Plaque is cholesterol.
Cholesterol and scarring and so forth. It's multi-components that make up this plaque that ends up narrowing the lumen of the artery that supplies the brain with its nourishment and oxygen. In addition to that, it's the jagged edges of that plaque that can rupture and shower upstream into the brain and result in disruption of the blood flow and neurological deficit, i.e. strokes.
Carotid artery is right here. I mean, that's where you take your pulse. Do you have one on either side, or just where is it?
So we have two carotid arteries. And both carotid artery, actually, they arise from the aorta directly or indirectly.
Okay.
So on the right side, majority of us, not all of us, will have a trunk called the brachiocephalic trunk that comes off from the aorta. and we'll divide into the right arm artery and a common carotid artery.
Okay.
On the left side, majority of us will have it arise directly from the aorta, and some of us not so much. We all have normal variants, and both of them will traverse internally within the thorax, meaning the chest, and will come up into the neck, and will subdivide further into an internal carotid and an external carotid. Internal carotid will go to the brain and supply the brain tissues as well as the vision, versus the external carotids will supply the external structures of the head and neck.
Okay.
The face and the neck.
What is the connection between stroke and carotid stenosis? You'd talked about that earlier.
The connection is the plaque buildup. Carotid stenosis is a leading cause of strokes. And strokes are a leading cause of death in the United States. About the fourth leading cause to be specific. And it is a leading cause of morbidity and debility in the United States for patients that suffer from carotid artery stenosis and subsequent deleterious effects, and that is strokes.
Okay, so let's talk about who's at risk, the highest risk for carotid stenosis.
You have to have multi-factors.
Okay.
Sometimes you could be a high risk and you only have one risk factors. But the risk factors, the more they build up, the higher the risk for strokes. And who's at risk? The older you get, the higher the risk. As with aging comes scarring within the arteries. High blood pressure is a major risk factor. Tobacco smoking is a major risk factor. Diabetes is a major risk factor. Other risk factors tend to be a little bit more obscure. Exposure to radiation therapy to your neck, and that's for folks that suffer from head and neck tumors that require radiation therapy to treat their tumors. So we see that sometimes in that patient population, but that's a little bit more obscure. The traditional risk factors, it's age, high blood pressure, high cholesterol, and diabetes.
The same things that cause all the other heart issues as well.
They inflict a similar damage onto the different vascular beds in our body, whether it's in the heart, the legs, or the carotids. The resultant deleterious effect is different from one organ to the other.
So does the carotid are there arteries that tend to build up with plaque faster than others?
You could look at it this way. High mileage arteries tend to have more buildup. The coronaries, the carotids, and the legs.
Okay. Because you've got more blood going through them, and that makes a lot of sense. Yeah. So if you have carotid stenosis, how do you even know you have it? Are there any outward symptoms at all?
Unfortunately, majority of carotid stenosis patients are asymptomatic. They don't know they have the disease. They don't know they have narrowing of their lumens. And when we find out, it's either it's been picked up on a routine exam or it expressed itself. It presented itself. And how does it present itself? There's three manifestations for carotid artery stenosis. The first is the worst, and that's strokes, which results in either prolonged or permanent neurological deficit. The second is what we call TIA, or transient ischemic attacks. Another common name for it is mini strokes. And this is a neurological deficit that lasts less than 24 hours. Finally, Latin term is amaurosis fugax, which is temporary loss of vision, and it lasts less than 24 hours. It's a subtype of mini strokes, but this is a warning symptom. And a lot of people would experience the symptoms and not pay too much attention to it because it's a loss of field of vision, not a total blindness.
So like you might not be able to see sort of out here.
Exactly.
Okay.
Exactly. And it is a warning shot that an impending stroke is about to happen.
Yeah, and we've done a program on stroke, and we have gone through the signs and symptoms of it because, as you know, if you catch it early, your chances of surviving and recovering are a lot better. So if the symptoms are rather vague and you don't know, are people with those risk factors, are they regularly tested for it, or what kinds of things should you be asking your doctor about if you're worried?
The first and the simplest, if you have multiple risk factors, a simple carotid exam with a stethoscope can suffice.
Okay.
And what you would listen for is a harsh sound of the turbulent blood flow going through the carotid because of a narrowing or just a plaque buildup and hardening of the artery. And you would hear a swoosh as a provider.
Okay.
So a carotid exam by your healthcare provider is the first to start off with. but not all narrowing will produce that harsh sound. And therefore, if you have the risk factors, some guidelines from the American Heart Association do recommend screening, utilizing an ultrasound or Doppler methodology to detect the flow across the carotid by measuring the velocities, and that could give us a very good idea of how narrowed the carotid artery is. But you have to have, of course, multiple risk factors, and you considered high risk for developing that kind of disease.
Okay. So at what point does someone end up seeing a specialist such as yourself for carotid stenosis?
Majority of the time, it's picked up as a carotid bruit is the term that we utilize.
Bruit?
Bruit. And that's the turbulent flow of the carotid artery. And it sounds like a swoosh sound, to be specific. So majority of the time, it's the healthcare providers picking it up and basically referring to the specialists. The other part, unfortunately, when it's too late, when you have a stroke symptom and the patients present themselves to the emergency department and so forth, and they're worked up for this, and we evaluate their carotids to see if it is the source of their strokes. And that's what we call a symptomatic patient. They've already expressed themselves as somebody that has a carotid stenosis.
Okay, so carotid stenosis, I want to make sure I have this right, that's what causes strokes. But when you have a blockage in your heart, that's what causes the heart attack, correct? It's the same mechanism just happening in a different place?
Yes.
Okay.
But there are other causes of strokes that could rise up.
Right.
But majority of the time, it's the carotid stenosis that we encounter.
So what's kind of the course of treatment that you go through? Do you automatically go in and do a procedure, or can medication like cholesterol lowering medication help first? We
do risk stratify patients. So what you have is a symptomatic and asymptomatic patient. And it's the level of the narrowing that determines the next course of action.
Okay.
So for symptomatic patients, those are folks that have either stroke, mini stroke, or amaurosis fugax, temporary loss of vision. We aggressively treat them medically, period, irrespective, and that's utilization of aspirin, utilization of cholesterol-lowering agents in a drug class called statins. And in addition to that, we modify their risks with respect to diabetes, with respect to high blood pressure. But if they have, with imaging, whether utilizing CAT scanning, MRAs, or an actual angiogram, if we demonstrate that there's a 50% reduction of the lumen of the carotid, they're considered high risk.
Okay.
You don't leave these patients alone, and you actually offer them, in addition to the aggressive medical strategy, you offer them an invasive strategy. And we'll get into that part in a little bit later. And that's either stenting or a surgical procedure. Now, patients that don't have symptoms, and we incidentally found that they have narrowing of their carotid arteries, we look at their risk factors. And if they have more than 70% reduction of the lumen, so they're basically hanging on by 30% of the original lumen size, then those patients are offered an invasive strategy in addition to aggressive medical strategy to treat their carotid artery stenosis. So
you rate the narrowing by percentage. So at kind of, if it's 10%, 20, at what point does it really get serious?
50% with patients that have strokes, 70% that are asymptomatic.
Okay. So do we all at some point have some cholesterol and some plaque buildup? Does everybody, unless you're ate perfectly your whole life, do we all have some level of cholesterol in our arteries?
We do, and there actually has been an older study from about 15, 20 years ago, so not that old, and it actually looked at juvenile autopsies. These are young kids that underwent an autopsy, and they looked at their arteries, and they found that obese kids that had plaque in their arteries, this was a direct correlation, the obesity and the plaque buildup in their arteries. It was not significant, did not cause narrowing, but there was a plaque deposition and cholesterol deposition in their arteries if they were obese. So there is a correlation. Can you be walking around young and still have plaque buildup? Yeah. Does
the plaque buildup in arteries come from the fat that we eat and the types of fats, like, high cholesterol foods? Is that primarily where it's coming from?
This is a direct source, yes, but not the primary source.
Okay.
I think all of it has to be put in together. It's the type of fat, like you said, makes a huge difference. But in addition to that, it's a sedentary lifestyle. You know, there's never been a direct correlation with high cholesterol level and strokes or high cholesterol level and heart attacks. It's been always considered a risk factor.
It's all that whole combination of everything sort of and genetics too. I mean, I know people that eat right and have really high cholesterol.
And exercise.
Or people who eat whatever they want and have really low cholesterol. So yeah, you're right. It's not just one thing.
It's multiple.
All right, so let's get into if you have a patient and their percentage of blockage is high enough that you need to go in and do something surgically.
So if medical management is exhausted and you do have a high risk feature for a patient, and you actually start recommending an invasive strategy. And the reason why we'd recommend that, in spite of aggressive medical management, if you have the high risk features, your chances of a stroke is still high. And you mitigate that risk of stroke by offering them a revascularization strategy, meaning you modify the plaque. Either you get rid of it altogether, and that's a surgical incision across the neck, and you actually scoop up the plaque and stitch the artery back, and you close it up. Or the alternative is a puncture wound in the common femoral artery, and basically you access the arterial system as a highway system to get them within the artery on the inside, and you implant a stent. And the stent's function here is to actually modify the plaque. How? By shielding it from the inside of the lumen of the artery and opening up the artery farther so you could actually supply more robust blood. But most importantly is you're excluding that plaque from the inner lumen of the artery. And therefore it won't shower and cause strokes.
So how do you decide to do the stent versus going in there and, as you said, scoop it out?
Stenting is a more modern procedure, and it has not gained a ton of traction to become mainstream. It is gaining more traction. More trials have been published to compare it to the more traditional treatment, and that's a surgical incision and scooping up the plaque out. And the data is actually very straightforward, showing very comparable results. Difference is the surgical procedure is invasive.
Right.
And it comes with risks of infection, recurrent laryngeal damage, and that's the nerve that comes and supplies the vocal cords. But it's a lower risk of stroke, but a higher risk of heart attack. So you have to weigh your options and risks and benefits. On the other hand, stenting, it's a higher risk of stroke, but it's a puncture wound. It's not a major incision, no risk of infection, negligible risk of infection and so forth, and no risk of a heart attack. So you have to weigh your risks and benefits. And if you go with the tailored guidelines, there are a subset of patients that right off the bat, they're considered too high risk for any surgery whatsoever, and you offer them stenting. At the Prairie Heart Institute, we do have trials at this point that we run, and we basically recruit the patients and give them the option for stenting versus endarterectomy or even medical treatment as well. So it's on trial basis as opposed to a mainstream treatment modality.
So which one of those are you doing? Are you doing more of the minimally invasive method?
We do stenting as an interventional cardiologist. I do not do the surgical procedure. We do have partners within the Prairie Heart Institute that do offer the surgical procedure. And majority of the time, we offer the patient both procedures simultaneously and offer them consultation with an interventional cardiologist and a vascular surgeon, so they can be well informed from both ends before deciding to go one way or another.
So I would imagine just the minimally invasive, the recovery time is a lot faster than having an incision?
The recovery time is about a day, 24 hours from the time of the procedure, and patients go home, and their recovery is based on the puncture wound itself. We give them restrictions for not heavy lifting and so forth, but it's a one-day procedure on average. The surgery itself, and it depends on the surgical center. Our center, we tend to keep patients for 48 hours or so, maybe less. It depends on how fast we control the blood pressure afterwards. Some centers go up to 72 hours where they keep their patients. The recovery is a little longer because of the incision and having to turn your neck sideways. And it's a little bit more rigid with the restrictions and the blood pressure management. If
you have that stent process done, is that permanent, or do you have to sometimes go in and do a little preventative or maintenance a few years down the road.
Hopefully you don't have to have maintenance, but if you have patients that have multiple risk factors and the risk factors continue to be uncontrolled and unchecked, and this goes for both endarterectomy and stenting, the disease can recur.
Yeah.
And you'd have to actually go and alter the plaque again. Unfortunately, if you go the stenting route, you cannot go the surgical route later.
Oh, okay. Why is that?
Because the stent is a permanent part of the carotid artery and you cannot cut through it.
So does that stent, we had a physician here that brought one, it looks like a little mesh. Does that, it actually kind of starts to grow into the artery?
Basically, the body forms some scar tissue within it, and it becomes embedded within the arterial wall.
Is it the same kind of stent material that's used in the heart? Are they all sort of the same, or are they a little bit different?
Mechanically, they're different because they have to have a certain, what we call radial strength to them. In addition to that, the common stents that we use in the heart, they're medicated and they're drug coated. We don't use that in the carotids. And the reason
why not?
Lumen size makes a difference.
Okay, when I was going to ask you, is it lumen, L-U-M-E-N? Is that, and that's the inside of the artery, or what is that?
That's basically the diameter of the artery.
Oh, okay, all right.
Kind of like a cross section.
Okay, so that's interesting. We're learning all sorts of stuff today. I'm like, I host a medical show. Sometimes I think I am a doctor because I've asked these questions for so long. But it's great for us as patients or potential patients to be informed.
Hopefully you won't be a potential patient.
I hope not.
And prevention is the cure. It's modifying the risk factors and not letting them take over your body, not letting them take over your health. Exercise, eat healthy, check your cholesterol, check your blood pressure.
Right.
If you screen for these early, then you don't have to worry about the problem later.
Do you have the patients that you're treating, do most of them, are they good patients and you don't have to do repeat processes on them? Do they follow the doctor's advice and direction?
Put it this way, it is a rare occurrence to have the recurrence of the disease. And a lot of times undergoing the procedure itself is really enlightening to the patient, and they become more educated, more empowered. And therefore the lifestyle modifications are taken upon them, and they're empowered and they're in charge of their own health because they don't want to come back.
Yeah. So do these people go through like cardiac rehab the way if you had a heart stent put in? Do they go through that same kind of process or
They
not?
don't have to, but about 40% of patients that have carotid artery disease, they actually have concomitant coronary artery disease. And somehow, some way, we figured out a way to plug them into the cardiac rehab side of things.
Okay.
And that's how we gained their attention with respect to cardiac rehab. But do they require cardiac rehab? No. It's the symptomatic patients that have suffered a stroke that will require a rehab, but not cardiac. It's more of a neurological rehab.
So when you have carotid stenosis, you don't generally have the shortness of breath and the weakness. It's more the stroke kinds of warning signs like you do with the heart.
Yes.
Okay. So I wanted to talk to you real quick about just some general heart health things that you yourself follow as a cardiologist. What advice would you give to all of our viewers out there for just good cardiac health, so that we, hopefully don't have to come see you at some point?
I try to exercise regularly, and I'm not doing it as robustly as I should. I think with having kids and having a career, it's a little difficult, and I'm not making excuses, but at least 3 times for me. But what I would recommend, 4 times a week of moderate intensity exercise. That is jogging, not walking,
not
jogging.
Strolling around the neighborhood.
If you do it in a more robust fashion and a brisk pace, and that'll help you actually achieve the moderate intensity.
Yes.
If you break a sweat, that was a good
okay.
exercise.
What did you said something before we started the show that's get the blood pumping through the system, that's really beneficial.
Circulating the blood is kind of like a healing process, an internal healing process. You circulate the blood, you heal these vascular beds, and you mitigate some of that disease that could occur.
So regular exercise, any great foods that you think are great heart health foods?
Well, I prescribe to a Mediterranean diet, and the primary choice of oil is olive oil. And in addition to that, believe it or not, carbs are a major source of energy. Red meat is out of the picture for the most part. It's twice a month that I actually consume red meat. I try to stay away from it as much as possible. It is difficult. It's everywhere, though. prescribed to white meat, mostly fish and chicken, and lots of fruits and vegetables as fillers, so to speak, you know, between the bread and the meats. Dessert is a fruit. It is a fruit. I'm glad my daughter is a big fan of that because she loves her fruits ever since she was a baby. And we do not consume as much cake or pie. It's mostly the fruits that we consume for dessert.
All right. Well, Dr. Al-Dadah, thank you so much for coming by the show and letting us become more knowledgeable about carotid stenosis and hopefully prevent some of these things from occurring in the future for us.
Thank you.
Thank you.
All right.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first.